Right, we're recording it. Sorry, I forgot to remind people with that initial confusion. If you don't want to be seen on this recording, switch your camera off. And if you don't want to be people to know you've been here for some reason to do with work or something like that, change the name on your person on the chat on the in the meeting. Sorry, I will start again. Apologies for that bit of a complication. I'm hoping Celia is here, and Celia is going to be taking notes for us of this meeting. Deborah has been campaigning for quite a while on the whole issue of the NHS and has been looking very closely at what's happening at the moment. So we'll listen to Deborah speak and then we'll have discussions. After we've had the discussion, we're going to move in at about 8 o'clock. We're going to move into reports on the area from the areas, and then try and agree an action list at the end of the meeting, or towards the end of the meeting. So Deborah, sorry for that very rough introduction. Would you please tell us about what's going on in the NHS?
Okay, well, thank you very much, Felicity, for inviting me. I'm feeling a little overawed because there's some of the great and the good in the whole sort of panoply of NHS campaign world here tonight. So I really hope that you'll bear with me and hope that I'm not pitching this at too low a level. But I will say that the way that I've chosen to approach this tonight is because I have been attending quite a number of meetings from local campaign groups across the country. And I am very conscious of a general approach to the white paper and to integrated care in particular, which is based on people believing that the white paper needs to be halted, there needs to be more time to think because this isn't going to work properly, this isn't going to integrate health and social care properly, that not enough thought's being given to it, and various things of that kind. So what people seem to be focused on is detail and process, rather than actual policy and objectives in what's going on. So I'm going to start with an old joke. A man takes his suit to the 3-hour dry cleaners. That'll be ready next Thursday, sir, says the shop assistant. Next Thursday, says the man, but it says 3-hour dry cleaners on the shop front. Sorry, sir, replies the shop assistant. That's just the name of the shop. So why am I telling this joke when I'm talking about integrated care? Because integrated care is a dishonest label, misleading about its content. It's not about collaborative working between local authorities and the NHS in order to improve patient care. Integrated care is a financial accounting system imported from the USA, designed to cut costs and enable profit sharing. And I hope tonight I can explain why that's the case and why it matters. Quite explicitly, through policy and legislation over 30 years, the NHS has been moved away from a public service to a mixed economy of provision. It's slowly bringing the NHS into line with the rest of the world. It's not exclusively a Tory plan. It has support from across the political spectrum. Health is big business globally, and healthcare like ours was publicly provided, owned and financed, restricts the business opportunities of foreign companies and NHS bodies alike. Polls show that a very high percentage of the population wants the NHS to be public, but politicians and think tanks aligned with global health interests have consistently moved it away from public service. This is reshaping healthcare to provide profit opportunities at every level. Because politicians know how much resistance there is to this reshaping, it has been done under the cover of consultations with predetermined outcomes, outright lies about what's being done, especially about hospital closures, and protestations of how much various governments love the NHS and would never, ever privatise it. When I say there are profit opportunities at every level, I start with the top level of policy and management because that's where it matters most. Most campaigns are centred on local cuts, closures, and reductions of service. That's where it grabs our attention. That's where it hurts. But if you don't look upstream at where the bodies are being pushed into the water, you'll be fishing them out downstream until everything you care about is gone. At this top level are some of the world's biggest global health insurance companies. Global management consultants advise on both sides, the government and the corporations. The big four accountancy firms, PwC, Deloitte, EY, and KPMG, are in there too. Not just getting contracts to provide services, but being paid to tell the NHS how to cut its services. We are paying people to take our healthcare away. This is not a question of lobbyists or influence. It's about who is running and making decisions about the NHS. And for any councillors who might be here tonight, it's for local authorities too. Outstanding moments from the last 30-year process include the supposedly independent Nuffield Trust, bringing US Medicare provider Kaiser Permanente's lobbyist, Professor Alan Enthoven, to advise Thatcher's cabinet on the 1990 Act, which broke the NHS into an internal market. New Labour's Alan Milburn, extolling both Kaiser Permanente and United Healthcare, brought Kaiser in to run NHS beacon projects with trusts and United Health to advise primary care trusts on how to run their systems. This is a process, not a one-off in the current white paper, and understanding that should strengthen the focus of campaigning. Both these interventions of United Healthcare and Kaiser into the NHS were based on a particular concern of the US healthcare industry, and they are important in terms of integrated care. It's how to reduce the cost of expensive patients, mainly those with long-term sickness and disability and the elderly. If I can emphasize here, this is about reducing the cost of expensive patients, not about improving healthcare. As the ideas of changing the way the NHS operates were being brought in, so the US insurance industry was concerned about its Medicare patients, who were spending about twice as long in hospital beds as private patients. And those many of you here who understand inequalities of health will know that the poorer population in America are the ones getting things like Medicare and Medicaid, and therefore the ones most likely to suffer the longest term consequences of illness. They developed the principle of day surgery with no overnight or aftercare provided for their Medicare patients. As one executive is recorded on camera as saying, "There's no profit in having the Medicare patients using beds. We free them up for private patients." They started to move to managed care, where the services a patient can use are limited by agreement between the insurer and a limited group of providers. Payment is made on a capitation basis, a fixed amount per registered patient. There's a thing called a risk pool, which is a critical component of healthcare payment systems, and it's fundamental to understanding integrated care. In a public service NHS, the risk pool is the whole country, and the payment is assumed by the government on behalf of the whole country. Estimations of cost are made at the beginning of the year, reassessed usually halfway through the year, then any shortfalls picked up by the Treasury at the year end. The government can decide to be tight or generous with funding allocations, but at the end of the day, the risk and the cost remains at national level. Not so with managed care, where risk is passed on to the provider group, and not so with integrated care either. Risk pools are concerned with who shares the risk. For example, the GP shares the financial risk with hospital care in some of the new NHS new models of care. In some areas of the country, we already have GPs being paid incentives not to refer patients to hospital. In a 2018 report commissioned by NHS Midlands and Lancashire Commissioning Support Unit from NHS England Strategy Unit, it states that risk and reward sharing is a key feature of the policy agenda for accountable care organisations in the US and integrated care systems in England. It offers commissioners the opportunity to co-opt and incentivize providers to moderate growth in healthcare demand by sharing in the savings or cost overruns. Risk and reward sharing can be seen as a step in the journey towards the full transfer of financial risk to providers. Those providers are the 42 integrated care systems. In 2012, management consultants McKinsey co-wrote the Health and Social Care Act with Andrew Lansley's health team. NHS England itself was tailored by McKinsey according to a model it set out in a presentation to the Department of Health in February 2011. An email from an unnamed McKinsey executive from May 2010, just as the coalition government was being formed, states, "We have been gathering our thinking on the implications of the new government programme for the NHS and has started to share this with clients. Would you like to meet us to discuss it?" The email was sent to David Bennett, then the chief executive of Monitor, whose role was to police the relationship between the private and public sectors. Bennett himself had spent 20 years at McKinsey, which you may know prides itself on its former employees never losing touch and always working together no matter what other roles they go on to occupy in their working lives. Bennett left in 2016 when NHS Improvement took over Monitor's functions and went to work for the Serco-owned pathology company Viapath. Just after the 2012 Act was enacted, it became officially labelled a mistake on all sides of the political spectrum. In our, that is Public Matters, analysis of the developmental path of the NHS from a public organisation to a set of fully public-private local health economies, the 42 integrated care systems, the Act was not a mistake. It was essential both to create a bigger rupture than had previously been achieved and to bring the private sector in at a scale and pace previously unachievable. These private providers are destined to become part of integrated care systems. Integrated care has been prefigured over the previous years, but started in earnest with the appointment of Simon Stevens to the post of CEO of NHS England. Stevens was part of Melbourne's New Labour health team, but spent the intervening 10 years in top positions in United Healthcare. Others in the running were Kaiser Permanente's CEO Bernard Tyson and Mark Britnell, the director at KPMG. These people were never being considered because of their long history of commitment to public service. I could spend all day listing the various movements between political office, advisory positions, and the private sector, and which companies are directly advising on service changes which will benefit them directly. But I hope that I've given enough of a flavour to make two things crystal clear. First, that the confederation of interest between politicians, global healthcare, and think tanks over the last 30 years, as well as right now, do not indicate that the NHS is being shaped and run in patients' interests. Although I will call out here for the extraordinary, slightly unbelievable dedication of staff who try to make it so unbelievably against the odds. And secondly, that funding hasn't simply been cut. The message that the NHS is being underfunded is one that we often hear. But the NHS has faced that before and weathered it. This is about directly funding in different directions to achieve a different purpose, one which favours profit. For 30 years, our successive governments have used language that sounds like care to cover for the dismantling of the NHS. Integrated care is yet another of them. It's not about collaboration between health and social care to improve patients' lives. That's why it seems so consistently to fail to meet its supposed objectives, because they're not the objectives at all. But no party has ever offered the electorate an explanation or allowed them a choice at the ballot box as to whether they want this. What can we do? Keep fighting locally, but build a more concerted national campaign to hit the top levels of concern, not just the local closures. Because I think this particular change may be much harder to row back from in the future, should we ever have a government, again, that truly believes in and will legislate for public service. Thank
you. Thank you, Deborah.
And you're all sitting there thinking, we knew all that.
No, that was excellent. That was really good. Thank you very much. I really enjoyed that. Do we have hands up for questions? Anyone want to raise their blue hand or wave at me? John Davis? If you unmute yourself, John.
Oh, can you hear me?
Yes.
Oh, right, yeah. Very important that. I mean, these referrals, referral systems, they're very, very low grade, very secretive. Not many people are involved in it. And it's coming through like the undergrowth in a way. But because a little bit I know, I actually confronted my GP because I didn't want to be sent to this referral management centre from Warrington Referral Assistant Gateway Management Centre. And I fought and fought and fought, and they argued against me. In the end, I've got an exemption now. No referral to RAG to be made for this patient. That is, I can have a choice of my own doctor without going through referral management centre. Anybody could do this. And I contacted the health service ombudsman, and he says, oh, very good. He says, if everyone starts doing that, the whole thing will fall apart, because in theory, you have a choice. So they said, the guy from the health service ombudsman said, it's a bluff. He said, technically, you don't have a choice, but if enough people challenge the surgery, just ask them, what do you do with referrals? That's when they start getting a bit nervous. My surgery, when I was asked, I wanted to get referred to this lump on my shoulder, which is all right, folks, so don't worry. I went through 4 doctors, passing from one to the other, to finally a little bit of a grubby room in the hub in Warrington, where the people there were doing this test, no qualifications, no clear ideas. I waited and waited, and at the end, I said, no, I'm not getting done by you. I want to know what's going on. And then I went back to the surgery. Surprise, surprise, I got an appointment with the consultant in the hospital. But these can be done. But what you need to do really as individuals is just say, hey, what's your referral policy? What is it? Just ask them that. The argument I had with my GP, I said, this referral management centre, where is it? And he says, Manchester. I said, no, it's Bolton. And I said, you get paid for this, don't you? I said, oh, I don't get paid. The surgery does. I won't go into the boring detail of it. It's corruption. And I don't know about anybody else's surgeries, but this, as you said, the lady said there, this is going on bit by bit. And it's great to focus on ACOs and ICSs and all that, but it's doing bit by bit. And I think we're going to have to get some sort of questions to ask surgeries and just do what I asked about it. I wouldn't have known about this if it wasn't belonging to the campaign. People don't believe that they have a choice. They do have a choice.
Thank you, John. Can I take a couple more speakers, and then maybe if Deborah has any comments to come back after a couple more. So Ray McHale next.
Yes, I mean, that was very interesting from Deborah, and perhaps the first time I've heard that full exposition of the sort of background situation. I suppose it leaves me a little bit up in the air in terms of the gap between that sort of ongoing process which has been running since Thatcher was in power to try and change our NHS and turn it into a source of profits, and on the other hand, the need to confront the current proposals relating to the white paper. And obviously there can be very big concerns about what the intentions are of the government and what their driving force is and what they're trying to achieve. But I think if we're going to get councils and even MPs on board for the fight, then we've got to translate that somehow into where we stand in terms of the proposals that are being put forward. I mean, we could just say, no, none of this is any good. We don't want to know. We're against everything you're proposing. But I can't see that being taken up by councillors and that who are already fairly steeped in these integrated care systems. But maybe there are some practical aspects about the involvement of the private companies on the boards, and whether the CCGs are abolished, etc. Which, I say, it's about trying to translate or fill the gap between that background message of where the Tories have always been wanting to take us, and maybe where even the Labour Party has been wanting to take us in terms of generating profit from the NHS, and coming forward with some practical issues and campaigning points now.
Thanks, Ray. I'll just take Greg and then maybe come back to Deborah if we could try and keep our comments so we can get as many people in. Thank you.
Yeah, I'd like to speak to some of the points that Ray has just raised, but I'll also relate it, I think, to what Deborah is talking about. I want to explain how the white paper actually provides for private companies to be involved in the management of the ICSs, which is not quite the same level that Deborah was talking about, because she's been talking about how they're advising the governments. But there is another level, which maybe she referred to, I'm sure she's aware of, which is to actually bring the companies into the management of the ICSs themselves. The same companies that Deborah is talking about that appear on the Health System Support Framework, which includes 22 US-owned firms. So there are two ways in which that's going to work. One is that they're going to have two different boards in each integrated care system, one of which is explicitly called a Health and Care Partnership Board. And on that board, they explicitly say that we will invite what they call independent sector partners, which means the private sector. That's what it means. The other body, which is the one that's going to directly write the plan and control the finance, is called the ICS NHS body, but that also has provision to bring unspecified others onto the board. And so if you open the door to somebody who's unspecified, it could turn out to be Centene or Cerner or PwC or whoever. So that's how the white paper allows the private sector on. But the situation we're in right now is not the bill, and it's not the law. It's a preliminary stage, which is what we're going to have to get to grips with in order to address what Ray is talking about. The situation in Cheshire and Merseyside is going to be a joint committee of the existing CCGs bundled together into one unit before any act of Parliament is passed. And that too will allow the joint committee to invite whoever they want to join the meetings. And it's not quite clear from the terms of reference whether they're going to get a vote or whether they're just going to be brought in to advise or whatever. And that's one of the issues that we're going to have to get to the bottom of. So it seems to me that what does address Ray's point is that these various councillors who are going along with it do say that they're opposed to the privatization of the NHS. But now you have explicit ways in the white paper and in the joint committee that's being established on the 1st of April for exactly that to happen. The last thing I want to say is that I think whilst it's true that for decades, every government has said we will never privatize the NHS, and no doubt Boris has said it, but that's not what Hancock is saying now, because there was a kind of confrontation between Rosie Cooper and Matt Hancock at the Health Select Committee last week, and he said, when she said, are there going to be private companies on the boards of these integrated care systems? He said, people who are opposed to the involvement of the private sector in the NHS do so for ideological reasons, and they're wrong. So that's the level of the fight we're in now. They're no longer pretending that they're not going to privatize the NHS. They're acknowledging it, and they're calling anybody who's opposed to that an ideologue. So that's what we are now. We're ideologues because we're opposed to the fundamental plan. And it's very significant, I think, that they're no longer pretending. You know, they've given up on that. They don't need that anymore. Anyway, I'll stop there. I hope to come back later on some of the local stuff.
Thank you, Greg. Deborah, would you like to comment on anything that's been said in those last 3 contributions, and then I'll bring in a couple more speakers.
Yeah, I mean, if I sort of start at the back with Greg, I mean, the last with Greg with what he's saying. Yes, absolutely. I mean, there's a about the way that they are, the private sector is directly embedded in the process, you know, with the ICSs, which I did actually say, rather than just at the government level. My local GP surgery, it is one of the ones that's just been taken over by Centene. Centene now, I think there are now the top 30 large-scale GP providers, which count as being corporate bodies, you know, sort of, you know, private sector bodies rather than as PCNs, which are, you know, the primary care networks, which are not considered in the same way. Now have between them something like, well, I think roughly 3 million patients signed up. That's a really huge wedge of patients in the country that are now, those are the top ones. That's not all of them. And all of those private companies, some of which are run by companies like Centene, are going to be they're going to be on the boards of CCGs. CCGs are going to be amalgamated into the integrated care units, care systems. So the commissioning functions are going to be directly influenced, affected, or even run by these organisations. And you have to remember that when the contracts are going out in integrated care systems for the provision of what they call population health contracts, which are the merger of sort of primary care functions, not just GPs, but across local authorities, care systems, you know, whatever, opticians, pharmacists and all the rest, that those contracts are going to be substantially larger than the contracts for running a GP surgery. So Centene could easily be stepping up from providing, you know, for earning whatever it is, £100 million a year currently from the contracts it's got in GP surgeries to £1 billion per footprint, if that's, you know, if that's the kind of extension range that it ends up with having. You know, the step change in the impact of the private sector through the integrated care systems is potentially enormous, and I think it's not stated. I do agree with you about Hancock. He also spoke at the Policy Forum, where he was asked at a press conference, where he was asked, and he said, the idea that the NHS is only a public sector organisation is for the birds. That was his phrase. He said nobody seriously thinks anymore that the NHS can cope without the private sector. And of course, you know, the engineering that's gone on for the last 30 years will make it extremely difficult to return the NHS to public service. And I think that anybody who imagines that you could somehow have a Labour government who would come in with that intention and boomf, wave a magic wand and boomf, it would all be public service again. It's been constructed for the benefit of the private sector. And that's a different kind of organisational structure than the one that you need for the public sector. I think the task with every passing year, as it feels at the moment, with every passing moment, the task of returning the NHS to public service, you know, and I want to kind of make a big sort of cry of, I mean, here about this. To me, the extraordinary thing is that in this country, which is has a capitalist imperialist history, that at this particular point in time in 1945, after the Second World War, when the Labour government came in, and we had these people, we had Bevan, who actually had the nerve to create the most extraordinary socialist organisation that was for everybody. It was just amazing. I mean, in terms of its time and its place, it was a complete outlier, and it has been hated by a lot of people ever since because of that. And I think people don't realise that. I think you have to remember the climate after the Second World War, the anti-communist feeling, you know, the Cold War and everything else. And here we were with a socialist organisation that looked after absolutely everybody in the country without them having to put their hands in their pockets to pay for it. Yet it's just extraordinary. The rest of the world hated it so much, none of them did it. you know, it's like, bad socialist organisation, don't want that. Bad healthcare. It's beautiful, it's wonderful. It was, and it's just being taken away from us so quickly now. It's one of those things, isn't it? When you go down the slope, you gather speed, and this is gathering speed. So when we're talking about how that's got to be fought back against, what can be done and everything, it's got to be something. It's got to be something much more coordinated, much more powerful than has gone on before. It's got to be more than people dipping into their campaign buckets and saying, oh, so we'll write a leaflet, we're going to do this. All of those things have their time, they have their place. But I don't think it's going to beat this. We're talking about something way too big. And I mean, was it John who spoke first about saying about his GP, who said about, you know, people can do this thing of saying that they don't want the referral system to be used, and then the system would collapse if people refuse to use it because you have the choice to do it. Well, I think that there are, I always feel sort of very inspired by that, but the reality is, you know, there were campaigns to get people to opt out of data sharing, and I don't think they were widely taken up, and there were campaigns to get people to try and say that to their GPs, don't refer me to the private sector, only to the NHS, and they didn't get taken up. You want this idea of something that would ignite the imagination and burn across the country. I personally don't know what that is, and I, you know, if Spartacus is amongst us and wants to stand up and come up with that bright and glowing idea that will sort of ignite the country, then, you know, please do.
Thank you, Deborah. Yeah, so anyone who wants to stand up, let us know. I've got Irene, then Felicity, then Leslie next. Thank you. Irene first.
Hi, thank you, Deborah. As usual, it was a brilliant exposition. I share the same fear and concern of you. It's extreme. And I don't know if this is right for you, but I wonder how groups like this can reach out to other people. I said at another meeting, I have a very, very gentle and caring neighbour who has a grandchild who's severely challenging behaviours and other things in her life. And I have my NHS posters, but I can see the shock in her eyes when we chat. If I say, oh, it really is important, it's as though she can't take any more bad news. And they're frightened, and they think I may be nuts. And I don't know how not to frighten them, but to say I want this to be protected. And I have another neighbour who actually stopped me, and she said, I always notice your posters, but I had to sit in A&E for a problem she had for 13 hours recently. And she said, you're right. She said, the staff never took a break. I didn't think they worked under those conditions, but it had taken her personal experience for her to see that something was not right. And so really mine's a general inquiry to anyone who knows how we can get the message across without making people put their hands over their ears and saying, stop it, I can't take any more bad news or frightening issues. I don't know if that's very helpful, but it is what I do grapple with.
Thanks, Erin. Sorry, go on.
I'm going to say, my sister, my elder sister, was one of the people who started the Save Our Hospital Services campaign in Devon. And her hospital services came under threat. And she rang me and said, oh, tell me all about what's going on. And I said, well, this is part of the new models of care. This is what will be happening. You'll be losing your services. They'll be going to Exeter. You're going to have to travel, you know, a lot of miles to go and get your care. And she said, no, it can't happen because we're in rural North Devon. And it's like, you can't do that. You can't do that. You can't take terribly ill people and move them, you know, 40, you know, rush 40 miles across the country at a minimum distance to, you know, to be able to access care. It's not possible. And I said, well, it is, and it will be, and that will be happening in rural areas all across the country and also in poor metropolitan areas. And she was really shocked. And I told her to go away and read the 5-year forward view, which she did, which actually remarkably few people do, I think, or did do. And she came back and she said, oh my goodness, she said, you're right. She said, I now understand what they're doing. Why are they doing this? This isn't going to give us good healthcare. That her first thing is, and I said, but it's not intended to. It's intended to create profit for the private sector. And for about 3 days, we had this sort of ongoing phone conversation where she was coming back to me and saying, but you're saying that basically like the government doesn't care whether we live or die, you know, that's sort of at the end point, you know. And I said, well, yes, if that's kind of how, and that's, how can you explain that to people? How can you say to people, even when they've seen with COVID and they've seen the response to COVID and they've seen how little the government actually cares about us, and they've seen the disgrace of the NHS having to send patients with COVID back into care homes where they've spread it and people have died as a consequence. They have seen these actions and still don't compute in their heads that it is possible for people, anyone, any government, to run the NHS not in our interests. It's huge. It's not, you can't address it. So how you do it, I think it's going to be different for different people. We have to keep trying. I mean, that's really the thing, isn't it? It's just never give up, never surrender. You just keep thinking of different ways of explaining it, thinking of different ways of presenting it. But it's to say to people the NHS is no longer going to be there to care for you is probably one of the most enormous and consequential things you can think of to say to people in this country, really.
Thanks, Deborah.
Oh, Lynn, is that you from SOHS Devon? Sorry, I just realised.
Yes, she just put that in the chat. The next person is Felicity, please. You on mute?
Right, one of these years. One of the points I want to look at is this thing of how we present the issues. And going back to the start of the Save Liverpool Women's Hospital campaign, we use this phrase for all our mothers, sisters, daughters, friends and lovers, and for the babies born there. And it really made an impact. It made an impact on the streets. It made an impact in the campaign that we were fighting. And I think that saying what we are fighting for, rather than saying to people how terrible it is a positive step forward. I'm a teacher by trade, and I'm a teacher of children with learning difficulties. And one of the things from that is that people take a long time to process information. That when we have to tell people things, you can see, especially talking about the NHS, you can see in people's faces their disbelief. And then you say it again and again and again, and eventually they begin to process it, they begin to internalize it and understand it. And I did a thing, I put myself down as a public speaker at our local health scrutiny committee. And I went through what happens, why the white paper is particularly dangerous for women. And you could see the kind of in people's faces listening to what I'd said. But you could also see a kind of click in some people's eyes as well. So yeah, it's saying what we want and saying it positively, and saying with confidence that we're damn well going to fight for this, and we're not going to shut up, and we're going to really be out on the streets as soon as we can, campaigning with stalls and going to community groups and all the rest of it. We're going to fight like our grandmothers fought for the foundation of the NHS, because in the history we did of the fight for the Women's Hospital, the early years of the Women's Hospital, we came across the fight that the Cooperative Women's Guild fought in the early part of the century, of the last century, demanding care for their for their children and for themselves. And I, many years ago, when I first got involved in the Labour Party, I met some of the very old women who'd done that. And they talked about how they were absolutely belittled and called stupid and all kinds of things because they demanded care free at the point of need for everybody. But they continued in that fight. And eventually, as we know, they won it. Where we are in Neston, where Celia and I live in Neston, there was a health system like the one where Bevan himself lived, where it was a health system that was paid for by the miners, paid for by the by people themselves. Now, we have a tradition, and we've got to go back to that tradition. We've got to use that tradition and be absolutely explicit. We want healthcare free at the point of need, without profit, without being used for profit. And it will develop into slogans as we go through and as we work this campaign. But we shouldn't be bowing the knee at all to people who say, oh, well, we've got to compromise here, we've got to find a way through it here. We want that care free at the point of need, and be absolutely explicit about it. I'll leave it at that.
Thanks, Felicity. If I can bring in Leslie, and then we'll go back to Deborah, and then we'll take Laura, if that's okay, and come back to her.
Okay, I'll just switch my camera off for observation. Just hang on a sec. Okay, yeah, Deborah, I agree with you that this is a national, top level issue, and it's not just about chipping bits of the NHS off anymore, even though big chunks have gone. This is really fundamentally about, we keep using this term, it's about the bakery. And it's handing over the bakery from the collective good to the private profiteers, for them to run the bakery, for them to decide who gets the cakes, for them to decide who gets the bread, and for throwing out a few possible crumbs at the bottom that we have to pay for individually or through health insurance. And I feel it really is the end of the National Health Service. And I do think we have to tell people that this is very, very different. And I totally agree that it is completely different. And yes, there are plenty of local campaigns. And I think we need to get the local campaigns to put their struggles in this context. Because the public, many of the public are unaware, but also even more worrying is that many trade unions, many MPs, and I would say most councillors are totally unaware of the consequences of this. They have swallowed the nice phrases and think and hope they can't do this. And some of them are willingly looking the other way because they don't want to fight. They can't believe it, and they don't want to fight, and they don't know how to fight, and then that's up to us, isn't it, to organise that fight. So I do think we need national coordination to really get a big national campaign across. There's some great international initiatives. I mean, Greg and Merseyside KOMP have hushed KOMP nationally and got some good material there, but all that different health campaigns, national and local, needs to be, really urgently on board with this. And I just want to say briefly how, a local campaign like Save Liverpool Women's Hospital is being affected by this, and the effect this will have on women, because the Women's Hospital has been a vanguard for the STP for the last couple of years. And the STP tried bringing in one-to-one private midwife company. It all sounded great, have your own midwife, and that collapsed into bankruptcy within a couple of years, and the Women's Hospital and others having to pick up the pieces from that. But that was part of the plan for maternity. Now we have the STP, a national agenda for continuity of care, which is again saying you should have a named midwife or a named midwife team, which is fine, but they're not putting a penny extra money into that. Liverpool Women's Hospital has been told reach 80% of births going through continuity of care, but you are not getting an extra penny for it. You are not getting 1 penny more. And guess what? Midwives are leaving because without extra resources, you cannot have that kind of system of healthcare for births. So, you know, that's having a knock-on implication already kind of behind the scenes, because one of these days people are going to turn up and find that Liverpool Women's Hospital now has a shortage of midwives instead of being previously fully staffed with midwives. Also, we've run our campaign for 5 years, but now under the ICS, the white paper, the decision could even be taken out of our hands for a phony public consultation. You could just go straight, could you shove Liverpool Women's Hospital straight to a merger with the Royal Entry without any reference to the Secretary of State. So again, you know, all our local campaigning and getting the public on board, etc., can just be completely overridden without any discussion publicly to find that the women's is upped, closed and shoved off over into the Royal. So I think there's lots of opportunity to link the local issues with this national issue, because this is really urgent. You know, the clock's on the 11th hour and we really have to do something about this. So I'm really glad that we've got a good number of campaigners here, but obviously we've got a massive job to do as well. And it's really good to hear you, Deborah, as well. Thank you.
Thank you, Leslie.
Thanks, Leslie. Deborah, would you like to comment on those?
I absolutely would like to come to speak to Leslie about, I mean, the issues that she's raised. I mean, they're so wide-ranging, really, really crucial stuff in there. There is a huge problem with the unions. Absolutely true that they're not speaking up with loud voices. They're not taking on, as it were, the protection of the NHS as being a particular issue. Obviously, they're more concerned. I mean, and it is, as it were, it's the right and proper business of a union to be worried about terms and conditions and pay. And they are fighting things like the what are they called, the subsidiary companies that are being made by created by some of the NHS trusts and foundation trusts. But I think that there is something really serious going on about staffing that people are not talking about properly. Right from the word go in the 5-year forward view, if you look, the new models of staffing are really integral to the way that you save money to actually make profit. And those include a whole range of things, and they are self-care. That's very large. So now when I go onto my GP service, the first thing I see is a whole, before I can even get through anywhere to make an appointment, ring someone, speak to someone, get advice. There's a whole thing about, have I tried going to a pharmacy? Am I actually okay anyway? Am I just bothering them for nothing? I mean, paraphrase, but you get the picture. It then says in the 5-year forward, it's then about whether you've got friends and family who can support you, whether there are volunteers in your community, whether your community has voluntary sector organisations that can support you. In other words, look anywhere except for the NHS for care, especially if it's unpaid. That's kind of like rule number one. So already, so as soon as you do that, you're undercutting the basis of a properly paid professional health service. If that's kind of your baseline where you're starting, make it all about volunteers, make it all about personal and friend support. The personal health budgets, that's another thing that undercuts the NHS and its staff and terms and conditions, because you can use a personal health budget or indeed a maternity voucher to go outside of the NHS to use whatever services you want. On our Public Matters website, Jessica Ormerod wrote a really excellent piece about maternity care, which Felicity is very familiar with, and I know that she's been and spoken at the Women's Hospital before about this, because there are a whole range of issues about who under the new maternity rules can actually be there for births. There ought to be a rule where everybody is entitled to a midwife at their birth. I think that right has been slowly but surreptitiously removed. But the unions do not seem to have got their head around, in my opinion, the fundamental idea that the downskilling of staff is going on consistently throughout the NHS. So there'll be fewer GPs and fewer consultants in the NHS, because the general principle is that everyone of lower grades can do things. Now, when I was a union convener in the 80s, if you had members of staff at sort of junior grades and you were going to increase their responsibilities, Then they got new training, and they usually got, and they may have got new qualifications, they got new grading, and they got new pay, because that's what you did if you improved. And then we got we got the new way of working, which is give them a nice title, call them something different, give them an enhanced work situation. And that apparently is a substitute for proper pay. And that's become sort of more or less established. So I have actually heard nurses say things like, oh, it's really great that healthcare assistants do what used to be part of our job, because it really makes them feel better and more of the team. Where's their money? And isn't that undercutting a nurse's position? So all of the kind of what I would think are core union arguments about staffing levels and pay have gone out the window, or appear to have gone out the window. I'm not hearing them, that's for sure. So there are issues there. So yes, the unions are a big thing, but getting the unions involved and getting to understand the kind of the overarching implications of what's going on here and why it matters to them. I also think that they have a particular problem because they are representing workers who are employed by the private sector. And there you have a huge, if you're going to have a campaign as a union that is actually not just supporting your workers in those private sector companies, but opposing the existence of the private sector companies in the NHS in the first place, that's new territory, I think, for a for unions anyway. The other thing is about people understanding local. I think really that what's really spoke to me, Leslie, as well, was you saying about local campaigns, because what is happening in local areas is they're microcosms of what is actually the national plan. And if we can start to use that information and use it as an illustration and get people to link up across the country to realize, oh, my campaign's like your campaign. Oh my God, we're losing our hospital for the same reason you're losing your hospital. You know, then people might be able to see that this is a national picture. Nicholas and I went to, Nicholas, who's here, and myself, we spoke to councillors at Basingstoke who hadn't realised that the American companies in fact it was Centene. This is before the AT Medics thing, that Centene was taking over GP surgeries all across the country. They hadn't realised the implications, but when we spoke to them, they said, "Oh well, we might start connecting up with some other local authorities and start talking and asking what the hell's going on here," because they knew that their ward constituents were losing services as a result of previous private sector takeovers of their GP surgeries. So getting people to illustrate things like that. Just before Christmas, just north of you, in Fleetwood, Cat Smith MP started to tweet about the fact that she was really concerned, having heard the plans that the Royal Preston and the Lancaster Royal Infirmary were both going to be downgraded and possibly closed because there's going to be a new super hospital. I think it's Blackpool Victoria is going to be made into a major trauma centre. And she was horrified. She said, this wasn't in our plan. This was never in our plan. This is really terrible. And I tweeted back at her and said, actually, no, it's part of, this is part of it. This is what it is. This is what the new models of care, integrated care systems look like on the ground. And I sent her a message on Facebook. She didn't reply. So I emailed her and she responded back to say that she was very, very busy fighting the closures of her two hospitals, but that Labour were very committed to the NHS England's long-term plan, and the disconnect between those two different things. You know, it's like, no, the long-term plan is why your hospitals are being shut down. That's why. It's nothing to do with local decisions. It's absolutely to do with a national picture of how services are being reconfigured. And that really alarms me. If at this stage in the game, a supposedly left-wing MP, well, let's say she's a left-wing MP, doesn't understand the concept of what's going on. She doesn't grasp the idea that the changes on the ground in staffing, in the closing of services, in the reconfiguration of services is fundamental to the future profit-making opportunities for the private sector. If you don't have that change on the ground, they won't be able to make as much money. If you don't have those changes in staffing priorities, you won't be able to make as much money. So they're all actually bound into the same things. And those local area campaigns show that so amazingly. And if we can bring them to if there is a way of bringing them to a forum, to bring them to different media, where we can start to show that and explain that and get those people, because if you talk to local campaigns like yourselves, you know, with the Women's Hospital, you know the issues so deeply and you see the reality on the ground for people, and it tells a bigger story and a better story, I think, And there's Jenny from
Mhm.
Chorley, who's one of those people. Yes. Yeah, then, you know, bringing voices out into the public, into sort of a group, people being able to repeat that story, people being able to see everywhere, every footprint, every 42 integrated care system. This is what it's like, and this is why it's like it. A national picture. I don't think anything could be better than that. Personally, I don't think anything could be better or more powerful than that. Where we do it, how we coordinate it, where it's displayed, where the information goes to, all has to be thought about extremely carefully. But I think that I mean, really, really grateful for that contribution about that, Leslie, because really you brought up incredibly important issues.
Thanks, Deborah. We have got Laura Hother from Nurses United has been waiting patiently to speak. We do have other people with their hands up, so I was going to bring Laura in first, and we do want to take reports from some of the areas represented here. So if Laura wouldn't mind unmuting and speaking for a few minutes. Thanks.
Hi everyone, thanks for having me. I do apologise that my camera's off. I normally like to see people and them see me, but I had no sleep last night, and then I was potting around about 4 a.m. this morning getting ready for my shift. So I've done a shift on no sleep, and now I look more than knackered. So you can just enjoy my profile picture with my makeup on. As Greg was saying, you know, with us now being titled ideologues, do you know what? I will accept that label, because you could also say I'm an advocate at the same time, and I'm exactly that. I'm a patient advocate, and I'm proud of that, and I will never, you know, go away from that. This white paper, you know, it's so dangerous, and we do need to be getting the message out there. You know, we've got the issues in that there may be fixed budgets, and it's, you know, prioritizing who has the care, who goes without care, and at the end of the day we know what that means. It's we accept the patient who's going to bring in the more money, and we're going to not accept the patient who is going to cost us the most. You know, and you get these companies all of a sudden pretending, thinking like in America that they are all of a sudden medical doctors. You know, for example, you know, if you go to this and then we go all private and insurance based, you go to, oh, a doctor says a patient needs this procedure, and then the insurance companies go, actually no. And it's like, how qualified do you think you are to be able to override a doctor's decision in the name of capitalism? It's just absolutely disgusting. You know, we've seen the government have no concern or dismay about any of the deaths. We've had, you know, over 111,000 deaths, and they don't seem concerned. We're even saying, oh yeah, I'll probably see a few more people die in a third wave. Like, they're just not bothered. They just don't see it from the ground, because they are not, you know, yeah, they're not normal people, I'm going to say it. You know, we've seen what's happened in the past with privatisation of the NHS. You know, we've got the longest waiting times and a poorer quality of care for our patients. And as a, well, soon to be nurse, as per my nursing and midwifery code, I'm required to preserve safety. And if I don't do that, then myself and other nurses will be putting their pins at risk. And I can quote that one of my domains requires me to raise, and if necessary, escalate any concerns you may have about a patient or public safety, or the level of care people are receiving in your workplace or any other health and care setting, and use channels available to you in line with our guidance and local working practices. Well, that's all going to be jeopardized if we go ahead of this white paper, because we're not going to be able to prioritize safety and give care to the level that we want. You know, further cuts and privatisation do pose a threat to patients and public health. It will cause further divides between the classes and care equality. We already see patients coming in, and you can see the divide of health between, you know, people who are in poverty. It's inevitable, and all that's going to do is make this gap bigger. And I cannot sit back as a health worker who, you know, sees that everyone should be treated, you know, equally and prioritised correctly, I cannot bear to see further division of what is already a massive divide in the health of people. I definitely agree. We need to start having our persuasive conversations and frame them in the positive light, focusing on the goals of what we're going to save and win. You know, it's very important, and we've got to remember, you know, when we're relaying this information to the public, it's got to be in, you know, simple layman's terms. You know, we can't go in there telling all these. You can have an information leaflet by all means with a bit more detail, but we need to get the message clear and concise and get it across. Like when we had with the women's slogan, they said how it caught on and people remembered that. It's also been mentioned about nurses, you know, praising healthcare assistants, going, oh, it's, you know, it's great that our healthcare assistants now do more jobs. And it's not so much to make them feel a part of the team, but it's actually necessary to cope with the understaffing and the demands of ward areas. I mean, now nurses also do many of the jobs that doctors used to do, and so on and so on and so on. So everyone is taking on more work, and the point stands that, you know, we aren't paid fairly for it, as NHS staff have seen anywhere between 20 to 34% pay cut since 2010. So, you know, it's time to pay and upskill our workers, definitely. You know, what they deserve. They are well trained, they're competent individuals who keep people safe and save lives every single day. We all need our NHS, and we cannot let this happen to our NHS. It's not for sale, and we need to just encourage that and believe that we can all stand together and demand working rights for NHS workers to ensure safely staffed hospitals, and raise our concerns when we see privatisation posing a threat to our public and our patients. Together we can save our NHS, but it must be a united fight. Thank you everyone for listening to me.
Thanks, Laura. That's really excellent. I'm sorry to keep you awake even longer. Laura, you have a Twitter storm every Thursday, don't you, at 8 o'clock? Would you mind? Yeah, so would you mind putting details in the chat of the hashtags and what people can do to support your campaign?
Yeah,
please?
That's great. Thank you.
Thanks, Laura. Right, we do need to get on to the reports. I'm going to take the last 3 speakers who've been waiting for ages. But if you could try and keep your contributions short. So I've got Nicholas.
Okay, hi, yeah, just a quick one then about, you know, Laura just mentioned the simple way of talking about it, and with Deborah and others. We've been talking about the, you know, this essential idea of paying people to cut and take away our healthcare, you know, calling it cuts for cash that an accountable care organisation works. You make cuts and you reward it by getting a slice of the savings. So it's a very simple idea. You're paid to take away this, and it actually grows from that, because it's essentially what it's about. That's me.
Thanks, Nicholas. Victoria, next, please.
Hi, thank you very much. Yeah, I wanted to come in on a few points that people have made, and I think the main message is that we understand now that this is like a national thing. It's got to be have a national dimension, and it's so disappointing and makes you want to weep when you look at the opposition and unions who are not stepping up to the mark. So I feel that the only way we can sort of change this is if we the people, we as an organisation, we as campaigners, put up the pressure on and you know, campaign and hopefully put so much pressure on that they feel that it's the right thing to do to come and support it, because it's so vital that the unions and opposition parties come on board with us. And it's been mentioned about how this is really a trade union matter, because once the 42 independent little health services are in operation, you can see, you know, if you're a capitalist manager, what you do then is you'd have local pay. You're going to do away with the national terms and conditions. So that's at risk with this. You know, if you want to make it clear why this is a trade union matter, if they can't think of it for themselves, we're going to have to spell that type of thing out. And the fact that what it's got to say about the white paper's got to say about the qualifications of the profession and the undercutting and the downgrading of the qualifications, we need to address that. And I think Laura mentioned in her contribution about that, and this is happening now. This is the thing. These things are happening now, and the integration is happening now. I mean, on our Going Local, our Cheshire and Merseyside Integrated Care Partnership, their latest newsletter is spouting out how now Simon Stevens has given the go-ahead for the last integrated care partnerships to go ahead, which includes ours. So now we've got 14.9 million people formally designated into the integrated care service. And I know that what's proposed in the white paper is a step up from that. But this is happening now, and people have mentioned how their neighbours and people they talk to, first of all, it's like disbelief that things can be happening because maybe they haven't had a personal experience, and you feel like you're like scaremongering when you mention that this is going to happen. So maybe what we need is a repository of people's personal experiences that we can say, look, this is a real example of what's happening. Like in my local area, with a member who has just suddenly come across the removal of earwax removal from the care that the NHS is able to now provide. So he's had his hearing aid maintained at the auditory department at the hospital. There's nothing wrong with it. They say it's impacted wax, it's going to need to get removed. And he's been told that the only way he can do this now is to go to Boots and pay £60 to have that removed. So we need these like concrete examples that we can show people, yes, we haven't got to wait for the white paper to be implemented. These things are happening now. And at what they call like the place level integration, I think this is so insidious. At the GP networks and the integration that's taking place at place level, who are configuring services without anybody say so, whether it be good, bad or indifferent, so that if you ring your GP to have your medicines reviewed, you don't go to your GP now, you refer to some like a pharmacist, or you'll go to a nurse practitioner instead of your GP, and no one's accountable for these decisions and how it's configured. So these, I feel that we need to be alive to what's happening now and to be able to amplify that. We need to really upgrade it so that we are a national campaign having a national effect. So, thank you, everybody. I've really appreciated everything everybody said.
Sorry, I was on mute then. Sorry, thanks, Victoria. Greg, did you want to make a quick contribution? Thanks.
I do want to comment quickly on two of the union aspects, which in fact Victoria has touched on, but I want to say a little bit more about them. But can I say that when it suits you, I want to explain what we know about the structure that's coming in and about the targets that they're going to be aiming at, because we've actually got that information now and we need to have that in front of us. So you tell me when you want me to talk about that. But the comments I wanted to make is I'm extremely glad that we've got onto the question of the unions. And I want to develop two of the points that Victoria touched on. One is about the prospect of local pay. It isn't just that a far-sighted manager would think of it. It's that they're changing the payment system, and the bulk of the payment that'll come through the ICS will be in these fixed element block contracts, or block payments is what they're calling them. And they say explicitly that this will replace the national tariffs and that the fixed rates will be set locally. What that means is that the money that's required to run the NHS in a particular ICS will be different per operation or per person, depending on the area where this is happening, because locally, well, 70% of the cost of the NHS is staff costs. So if you change the money that's coming into the system because you're changing replacing the tariffs, then you're going to change how much money you've got to pay the staff. That's how it's going to work. So the point that Victoria is referring to is extremely important. It's the basis on which they can take apart a national pay system. That's the one point. The other point is about deregulation. In the, which again she touched on, in the white paper, there's an amazing section where they say this is not about deregulation. And the very next sentence says, over time and with changing technology, the risk profile of a given profession may change. And while regulation may be necessary now to protect the public, this may not be the case in the future. I mean, on the face of it, this is an incredible thing to say, that if we bring in enough computers, we won't have to regulate it to protect the public. That's incredible. It's, you know, the computer, I mean, it just doesn't make any sense, but it's also obviously extremely dangerous. So both of those points should be points for unions to grab. And I think we just have to go back to them, as well as the other things that people have said. Now, you tell me when you want to hear about what the specific plans are for the Joint Committee, because they give us opportunities to home in.
Thanks, Greg. While you're on, would you like to give a very quick report on what's happening in the Liverpool area?
What I want to tell you is what Liverpool CCG is saying about the system that's going to come in, because I assume what we want to keep this whole focus on is the white paper and the integrated care system, you know, things that might be happening in Liverpool or whatever.
I think, well, we were going to take a quick report from each of 8 areas on what the situation is, where they are, and then talk about, and then Felicity is going to talk about coordinating this group.
Well, all I'd ask you is that at some point in this discussion, let me explain what is actually about to happen with the joint committee that's being set up and what their priorities are and what they are going to set out to make Cheshire and Merseyside wide decisions about, because that is what we're going to have to focus on in order to get to grips with the move towards an integrated care system. I don't have to say it now. I'll wait until you've had the reports, but we've got to get to this.
Okay, Felicity, did you want to come in there?
Yeah, I think Greg should explain it now. If he's got information we need, he should explain it now.
Okay. Yes, please, Greg.
Okay, this is undoubtedly going to happen in every CCG. There's 9 CCGs now in Cheshire and Merseyside. And what's happening is they're going to form a joint committee that will operate over the next year. And that is the halfway house towards an integrated care system. It's the pooling of the CCGs, but it is not the pooling of the CCGs with the GPs and with the trusts and the foundation trusts. That won't happen until the white paper turns into a bill and gets adopted as an act of parliament. And so all of that is a year away. But in the interim, all the CCGs are going to form one body, a joint committee. And what that joint committee will do is it will take binding decisions that all the CCGs have to obey, but it will do so only on a limited scope. And that limited scope will probably expand during the year, but they are starting with 3 issues. And I'm just going to read this out because this is what we're going to have to focus on in order to get to grips with the activity of this committee. So just give me a second to find it. Okay. three areas they're going to take on board at that regional level. The first one is mental health services, and under that they have specialist community perinatal mental health services, children and young people mental health service, crisis services, eating disorder services, improving access to psychological therapies, IAPT, to address widespread variation in access, provision, quality, and outcomes, adult crisis services, out-of-area placements, and inpatient services. For each of those things, and that's just the mental health side, they are going to be commissioning and decommissioning services. So they are going to be cutting things and replacing them with other things, and we're going to have to understand the detail of what they're about to do. The second area is acute services, and they only say two things about that. One is to undertake activities to support provider collaboratives to develop and mature. Now, this is the sort of gobbledygook that the health system support framework is all, they're all over that sort of stuff. I don't know what they have in mind, but I can imagine they're going to bring in companies to tell the Women's Hospital how they should integrate with the Royal and with Aintree. And that's what we're going to have to find out. And the other part of acute services they've got in the frame is specialist rehab services for neuro, mental health, stroke, and complex cases. So again, we're going to have to understand what the existing provision is and how they intend to contract it out. And the third one is bariatric services. This is obesity, and they explicitly say to reprocure bariatric services during 2021-22. So that's their agenda in terms of specific areas. The other thing which concerns us is the form that this committee is going to take. They say that it will publish its minutes and that it will meet in public. But when you read the terms of reference, what that means is that the public can attend and listen. There's no provision for the public to ask questions. There's no provision for the public to see the papers beforehand. The papers will be shared with the committee members. To top it off, they have a provision whereby they can invite somebody else to turn up at the meeting from any organization that they feel is relevant to what they're trying to do. And so that's what I mentioned earlier. That's how the private sector could turn up at these meetings by their invitation. Now, it seems to me that we're going to have to get to grips with the fact that we won't have all the information, that they're not offering to do what the CCGs currently do, which is to publish the papers in advance. We're going to have to find out when the first meeting of this thing is, and we're going to have to figure out how we intervene. If we turn up at the first meeting, if we kind of get into the press when they're having the first meeting and demand that they open the books. We want to see what they're doing. And currently, there's no guarantee that we will know what they're doing. We only know what their aims are. We don't know what the process is going to be. So anyway, those are the things I wanted to make sure that everybody is aware of. The other thing we're going to have to understand is the finances. We need to know whether this is going to be some ginormous operate right away. And in order to understand that, we're going to have to know what the financial position is throughout Cheshire and Merseyside. We're going to have to know how much debt each CCG is in, because all of those debts are going to be pooled. And then the government is going to say, well, here's how much money you've got for Cheshire and Merseyside for a year. And you take the difference of the two, and that's the cut. So this is what the article in the lowdown that Leslie circulated earlier today is about, but it doesn't have those figures for Cheshire and Merseyside. We're going to have to get them. Okay.
Very much, Greg. Deborah may have to leave, and I just wanted to thank her very much for her contribution today. Tonight, it was excellent, and I think it's really helped us to understand and focus in on what we need to be concentrating on to further a joint national campaign and a local campaign. Thank you very much for your time.
Thank you so much for inviting me. And as I say, as I said to you privately, Felicity, a little overwhelmed by the audience because with people like Greg and Alex, well, actually, there's so many of you here, yourself, Felicity, all kinds of people here who are just so expert. It's amazing to be in scope, and thank you so much for letting me have the opportunity to speak. I have one small request to make, if any of you are happy to do this. As Public Matters, we have a crowdfunder going. Some of you may have seen that we've made short film explainers about what's going on about privatisation, about who's ownership in the NHS, and about the integrated care process. They're very short and they're going out on social media. They're doing quite well. Thank you, Mary. And we would like to make more, but they cost money to make. We have a crowdfunder for it. If anybody knows anyone who's got some dosh, or if you've got any yourself, please pop it in the pot to help us to make more. So that's my kind of my little humble request to you all. Thank you, and again, thank you. And I have to go now. Bye.
Thanks very much. And if we've got the link there, so Nicholas has put it in the chat there. Thanks very much.
Bye.
Thank you, Deborah. So Felicity, did you want to come in next to just explain what you're looking for from the different areas represented, or do you want me to go straight into asking for reports?
I'll explain first, if that's okay.
Okay.
Obviously, we're now running a bit short of time. We're not going to be able to spend as much time as we'd hoped on this at all. What I'm going to suggest is we have a very quick run round with what people are doing, and then that we still agree that we have, one person from each of the areas to agree to run emails between them to coordinate. So we've got some level of coordination about what's happening in the different areas. We are and shout out if I'm wrong, please, but I don't think we've got anyone here from Knowsley. Am I right? Is there anyone here representing Knowsley? No, so we've still got areas where we've got to go and dig out, people we know are working on the issue, but just aren't involved in this coordination. So we've still got some technical stuff. So really, we need to ask how long people are prepared to stay now. Are you prepared to stay roughly can you wave at us if you are prepared to stay for 10 more minutes?
Sure.
Okay. So yeah, sorry, Mary, I'll hand back to you and sort of take the reports from the different areas. Mary, you're muted.
Sorry, I was just trying to scroll back to where my list was. We've heard from Greg. And we haven't got anyone from Knowsley. I think we've got someone from Wirral. Can we have a report from Wirral? Thanks, Frank.
Okay, yeah. Yeah, basically, I mean, we're part of Merseyside and Cheshire, so we know what's happening as a whole there. In terms of what's happening on the ground, Margaret Greenwood, who's one of the MPs for Wirral and is very supportive, she's a founding member of Dons and so on. She's been working away on the white paper side of things, basically. And we're going to have a meeting with Margaret, Defender NHS on Wirral, sometime as soon as possible after this meeting. Really, we wanted to see what was decided at this meeting. We've also got a chair of adult health who's sympathetic, to us. Now, it's a question as well. This really, I mean. Wirral Borough Council has done all it could to cooperate with the government on privatisation in the ICS and so on over the years, inviting in American companies and so on. Yvonne took over last September with a different attitude, and I know she's trying to resist as much as possible. Is she really, flogging a dead horse? In other words, is it a waste of time now? Apart from saying this is wrong, but can local councils do anything now? That's That's a question, I suppose, because we would want to be suggesting things to her, really. I mean, the vast majority of councillors on Wirral haven't got a clue, you know, well, about anything really, but you know, they just haven't got a clue, and probably a lot of them don't care anyway. But there are about half a dozen who do. Well, there's probably more than that, actually, to be fair. But yeah, but I mean, can we just, you know, are we beyond now needing to bother with the councillors? Is it bigger than that? You know, should we be talking about taking on the government and so on, and the local, the local sort of broader ICS setup? And I mean, just on the question of getting out on the streets and so on, there's no reason why we can't go out on the streets at the moment, as long as we've got masks on and we're socially distanced. And I think from the 29th of this month, things are going to loosen up on that as well. So there's nothing to stop us from going out. Might have to do things in a slightly different way. I'm very involved with the Zero COVID campaign, and we've had a number of outside demonstrations. I mean, the police can stop. The police do what you like, you know. I mean, you know, but that shouldn't stop us, of course. But I think, you know, at some point we've got to get out there, and we've got to make our position felt somehow. You know, it's vitally important. Okay, cheers.
Mary, you're muted.
I've done it again. Sorry, have we got a thanks, Frank. Have we got a representative for Cheshire? Anyone for Cheshire? Is that Ray? Is that you?
I mean, just in terms of what we've been doing, we've been meeting as a West Cheshire group, but we've been linking up with Bob and some people in East Cheshire, in Crewe, producing letters to send to councillors, Labour Party constituencies, MPs, etc., to try and sort of get them understanding more what the issues are. And we're meeting pretty regularly to try and do that. So obviously, you know, this is part of that broader process. Celia went to a Northwest TUC the other day, which was quite interesting because there was pretty well nothing on the agenda about the NHS, I think, except about NHS companies and the terms and conditions they may pay to staff. So there's nothing generally about the NHS and the white paper and reorganisation even being discussed at the Northwest TUC AGM. I did speak to Justin Madders, our MP in Ellesmere Port, who's one of the shadow health ministers, and you know, he's sort of very vague on things. It's almost like the Labour Party are waiting to see what the situation is and trying to fathom things out themselves. So they haven't got any clear position. But you know, I think that they're open to be influenced in those circumstances if we can be specific. I mean, I think the two things that come out of tonight, which are, from my mind, is that I attended a meeting where the chair of the ICS board spoke to our Cheshire West Health and Wellbeing Committee, and you know, there was some discussion about some. He suggested that the issue of whether ICSs do all the procurement is not yet decided. You know, so the issue of whether they subsume all the CCGs is not decided. So it's interesting what Greg says about them coming together to you know, deal with certain issues. But you know, clearly, you know, we have some ability. He was basically saying, you know, that's for the board to decide, and each council will have one seat on the board, etc. So there may be some ability to influence whether those CCGs all remain in place with the ICS having some sort of overarching role. I don't know. And I think the other thing is to try and get some commitment from individual councils that they will oppose any private sector seats on these boards. You know, that's something that councils could very clearly take up. It was part of the white paper consultation, and they could commit to that sort of approach.
Thank you, Ray. Do we have a representative for Crewe? If we could try to just give one or 2 minutes of reports.
Yeah, hi, Bob. Yeah, I sort of look after Cheshire East by myself at the moment, unfortunately. So I've been sending out letters. So 2 letters have gone out to. I sent them out to all councillors in Cheshire East and the MPs, and I think I got 2 responses. So we sent out the second one only to the Labour Party councillors, and I've had no responses. So I think, as I've said before, I'm underwhelmed by the uptake of any feedback from councillors. What else was I going to say? I'm a Labour Party member, and I've been in contact with Crewe and Nantwich Labour Party. They are going to hopefully send out a letter to councillors and MPs. Although in Cheshire East, all our MPs are Tories, so I'm not sure we'll get far with that. Yeah, I think I really need to get other people involved in Cheshire East. I've failed at the moment. I think the thing that's come out to me from all the chats that we've had tonight is I thought it was complicated, but now I know it's hugely complicated. And I'm not sure how we get a message out to the public, because if they're like me, they haven't got much of an idea of what's going on with the NHS. I think it's important that we get the public informed, as well as our councillors and such like.
Thanks, Bob. I think that part of the reason for this joint campaign is for us to all support each other. So although you've been on your own, I'm sure there's plenty of us can give you some help with trying to reach other people. Thank you. Is there anyone from Sefton who'd like to report back?
Yeah, I will.
Thanks, Anne.
Linda might want to say something about Southport, but basically it's very similar to what other people have said. On the letters to councillors, I think sent them to all the Labour councillors, to all the independents, because I wasn't sure where they stood, and to a couple of the Liberals who have responded favourably in the past. I didn't bother with the Tories because it was a waste of putting my finger on the button. But of all those, I think there's about 5 responses. Interestingly, there seemed to be more response from north of the borough, which is a bit of a shame, than south, but that probably reflects the complacency amongst a lot of the councillors. I did have a bit of an interchange with one of the Thornbury councillors, very pleasant, who said, oh, I needed to contact my local candidate councillors. So I said I had done, but it wasn't a local issue, because it's obviously the National Health Service. And in the end, she said, responded, oh, I've just written a letter to the Health Secretary. Didn't tell me what it was saying, but I don't know whether that was a response. But I mean, it's difficult to be positive about that response, because these are people you elect and expecting to have the finger on the pulse, don't they? And a lot of them, it's either, I know it's a difficult issue, but it's a prime issue, is the future of the NHS. The CCG, they send out newsletters. The last one I forced myself to read to see if there was any mention of them amalgamating with any other CCG, and there was not a message about it at all. So in other words, if you get that and if you read it, you wouldn't know there was anything going on. So it's rather dispiriting. The only good thing, I think, is the poster campaign that we've done, Liverpool and here, which of the NHS. It's amazing, those posters have been up for about 6 months now. So hopefully it'll be a constant reminder to people as they go past. So I think we'd probably more likely at the moment get a response from the general public than from our elected representatives. But there are a couple of positive responses, people at least chased it up. But you expect far more than that, don't you, really?
Thanks, Anne. And I was going to come to Southport next. So who would like to give the report from Southport? I think we've got Linda and Michelle here, haven't we? Let's see. Is anyone putting their hands up for Southport now?
Not really. I don't think we've really
Okay.
I haven't been doing much.
All right. Thanks, Linda. Warrington? John?
Oh, hello. Am I
Hi,
there?
John.
Can you hear me?
Yeah. Yes.
Oh, yeah. Well, a bit of a breakthrough. We've got a good MP, Charlotte Nichols, who's expressed very great interest. So passing stuff on to her, through me. Yeah, what's better than the previous one? I've got a sort of informal meeting with councillors the next week, like a sort of a samostas. I don't know what's wrong with them. They don't seem to want to say anything. But I've got a sort of informal chat about what's going on. And, RCCG, quite well known for its rather roguish performances. Halton CCG has gone into Warrington CCG, and they've got a new headquarters for both CCGs in Warrington. And of course, it's closed. So they're just shifting this CCG around from Halton to Wirral without telling anybody, from Halton to Warrington without telling anybody. So, the usual blatant disrespect for people. But I'll send out some details of what I get from the councils, what they have to say, what their responses are. Well, good news, we got Charlotte Nichols. She's very interested, and hopefully we can get some involvement with her more.
Thanks, John. And then the last one we've got is Lancashire, and I was going to see if Jenny wanted to give an update on what's happening in Lancs.
Hi, Mary. Oh, you put me a bit on the spot there. We obviously we've got the ICS board. We put that back for going forward last year. That's due to come into the ICS board is due to come into its own in April this year. They're currently pushing in Chorley. Obviously, we've had a campaign to stop with, for this consultation on closing our emergency services, our A&E unit. Matt Hancock has come in and kiboshed the whole thing. He said that our A&E will now stay open. There is a caveat, and that caveat is until further plans in the area are confirmed. Within the day before he gave that update, our ICS board put out the plans for Lancaster. Well, it's the new hospital programme, which has been renamed from the national campaign for it's the HIP campaign, the Hospital Improvement Programme. And that basically is looking for either a 1 or 2 hospital new builds. This will get rid of Lancaster Hospital as it is now, and Preston Hospital as it is now. And it will either build, like I said, 1 or 2 new hospitals. The business plans actually say that the favour of that in the past has been that there's just going to be 1 new hospital. So the other plans within that have come about, these are more rumours than actually on the paper at the moment, is that Karen Partington from Lancashire Teaching Hospital Trust, which is Central Lancs, Preston and Chorley hospitals, is due to retire next year. And there are plans that the CEO from East Lancs Hospital, Blackburn Hospital, will take over her position. He's already taken over Blackpool. So given that Southport and Ormskirk hospital services have moved over to Merseyside and Cheshire, that will mean that every single hospital service within Lancashire and South Cumbria will then be under the same control. So obviously we're looking there at these big consolidations of services. We're fighting that at the moment. We're trying to get into it. We're not getting much from local councils. We're not getting much from county councils. One of the questions at the Health Scrutiny Committee was, do you think we could have a when you do these cuts, do you think there'll be a train service? I mean, that's how bad the scrutiny is. So we're really just trying to push that accountability, the transparency. They're not having any of their meetings, these public meetings that aren't, meetings in public that aren't public meetings. They're not putting those out to the public, except under ridiculous circumstances. You've got to email a week before, blah, blah, blah. It's really difficult to get hold of the information, but we're starting to push that. And I'll give you another update next time when we get a bit more information.
Thanks, Jenny. We don't have anyone from St Helens, I don't think, either. Felicity, did you want to come in and talk about the coordinating committee, or shall I bring in the 3 people with their hands up?
I won't be long on this. I think big meetings like this are really useful, but we also need to be coordinating on a more regular basis. And I think everyone on this call is involved in lots of different work. So I don't want to set up a separate organisation. What I'm suggesting is that we have one person from each area, and that one person, we decide either to do an email group or something like that, where people can just contribute what's going on in their area, and we can just keep in contact and keep the information flowing. And secondly, offer help in the areas where people are just starting up and where they might need, to have somebody else helping them in, going through what the situation is, and just trying to be very practical about it. When the Wirral's got a really well-established campaign, Cheshire West is doing fine at the moment. At Liverpool's well-established, but where people are just trying to start up, and we're hoping that will happen, we need to have this coordination. So do people agree that we can have the coordination? We have a coordinating committee, and then, I'll write to all of the areas and ask you to give me a nomination for who's going to be your person that's going to keep in touch. Okay, thank you. That's really good.
Thanks, Felicity. Nicholas with his hand?
No, I think that was an old one that stayed up from before.
Oh. Then I've got Ruth. Did you not put your hand up either?
No.
Okay. All right. Good. so we've dealt with all the hands up then. So Felicity's going to write to everyone. Thank you everyone for coming. It's been a really interesting meeting, and we've still got 30 people here, stayed till the end. Any questions, we can write in with any other questions and suggestions. And thank you very much. Enjoy the rest of your evening.
Thank you, Mary.
Thanks, Mary.
Thanks,
Mary.
Bye. Bye.
Take care, everybody. Bye.
Bye.
The recording.
Bye. 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 Bye.
Thank you, everyone. Thank you, Mary.
Bye.
Thank you.
Bye. Bye.
Thank you, everyone.
Thank you.
Susan, are you still there? Susan Keegan. What do you think about getting hold of the GMB together?
Oh, Felicity, I was going to speak to you, but I mean, last week, yeah, I am. I don't know where to start, Felicity.
All right, well, write to me.
Okay, very briefly, I had a member of the GMB up in Bolton contact me last week. About was it the ICS?
Yeah.
Yeah. It was about the integrated care systems. No, that was that was about the integrated care systems. Could I explain it? Could I give her any information? And so I've sent her some things out about that. Yeah, and Billy Goulding.
No, on the girl, it was about the payment systems.
Yeah.
That
that they were thinking that was going to be introduced.
Yeah, she basically she doesn't know very much about the ICS, and she's asked us, so she's framed it with, you know, asking for bits of, you know, important information really, so she can speak to her members and all those, and where she works in Bolton County Council. The other person that contacted me was the person in charge in the GMB of the retired members, and they'd come across the London, you know, the
GP
Centene, the GP contracts. And he said, what can we do? And is there anything, you know, we can help? So I've sent him over some information on that as well. So